Can you walk us briefly through the process of the first time you get oxygen equipment? You mentioned sometimes it just kind of gets dropped on your door, but how do we get to that point where somebody is prescribed equipment, have it delivered, and start using it?
That process typically begins in the clinic when we evaluate a patient or having a routine visit. If a patient is telling us they're more short of breath than normal, they may or may not have a pulse oximeter. So it's important for the patients to let us know their symptoms have changed. And we would check oxygen saturations. And it's very important to do this not just while sitting, but during exertion. So the most common test is a 6-minute walk test, which is a timed test where a patient is instructed to walk as far as they can and cover as much distance as they can in 6 minutes. And during that walk, we monitor the oxygen saturation on an oximeter and document if it drops below 88% or hits 88% or goes below that, because that qualifies a Medicare patient, for example, for oxygen. And we also measure the distance of how far that patient walked. The second type of test is a little less complicated. It's just what we call exercise oximetry. And there we simply walk a patient with a pulse oximeter and just determine if they drop their saturations below that 89, 88%. And then that's the first step. If that patient does drop below 89%, the next step is to say, well, how much oxygen do they need? And then we do an oxygen titration test. So we would start that patient at 2 liters a minute, walk them and document, did the saturation rise above 90? If not, we would stop, rest for a few minutes, and then turn it to 4. We typically go up by 2. We could go to 3. But we increase the oxygen, walk again, and let's say now the saturations are 93, 94%. So for that patient, their oxygen prescription would be none at rest, because they didn't desaturate at rest, 4 liters with exertion. And if we wanted to know about sleep, we could do an overnight oximetry test. This is not a full sleep study, it's just an oximetry test. And we could do that as well. But then that order for oxygen, 4 liters per minute with exertion, and the documentation, the walk test, the resting and exercise saturations with and without oxygen, all of that is written as an order and documented and sent to a local, we call them a durable medical equipment company, a DME. And that company will confirm that all the documentation meets the requirements of the insurer. And this can vary across other insurances, private insurances, different DMA, different Medicare Advantage programs, and there's a variety. So the company confirms that we've met all of their documentation criteria and the patient actually qualifies. And then we hope that that company will, in a timely manner, contact the patient, find out when they're home, and they will deliver 2 types of equipment. One is stationary. In other words, it stays in the home. So it's a stationary concentrator and it stays at home. It's not portable. Something that you would use with a long cord, a long cannula extension, and move about your house within the home and use this. It runs off electricity. The second piece of equipment would be your portable equipment. And this could be in the form of a compressed gas, a hard green tank of different sizes. Some go in a backpack, some go on a trolley that you pull, or it could be a portable oxygen concentrator that runs off a battery and basically extracts oxygen out of the air around you and concentrates it. And these run off a battery, they're portable. And as I mentioned earlier, they're more limited in the flow rates and the amount of oxygen they can deliver. So the typical setting will be up to 4 or 5 on a pulse setting. So this means it only delivers oxygen during inhalation, when you breathe in, and it triggers it to do that when you breathe in. And again, it's important to be tested on these. Some patients with pulmonary fibrosis when they exert themselves, can have a very rapid, shallow breathing pattern. It doesn't always trigger perfectly. So again, the mantra is check yourself with exertion on your equipment by looking at your pulse oximeter and making sure your saturations are over 90%. So if that's a POC, an E-tank, whatever it is. There is a third form of oxygen, liquid oxygen, which is more difficult to come by, which unfortunately is unfortunate because it can provide high flow in a portable unit, and patients can refill this from home. This is more difficult to come by. It's more costly for durable medical equipment companies to provide. So when your stationary and the portable equipment are delivered, the expectation is that that delivery person will instruct you on how to use both those systems. It'd be nice to have somebody else around, a family member or friend that can listen in. They'll tell you how to maintain it, what to expect if they're going to deliver tanks every week, or if you have a different system that doesn't need delivery, how often they're going to maintain your equipment, who to call if there's problems. And they should be giving this to you in writing. So you should have some written educational materials and know exactly who to call if you have questions. And then, we would hope you could use this equipment. And then when you see your clinician next, kind of report back. Yes, I got my equipment. I've been able to use it. It's helping. It's not helping. I can't lift it, whatever. We want to know how it's going. And the other piece to this, it's very important to be retested. So talk to your clinician. We don't just deliver equipment and forget about it for a year. We want to retest you and make sure it's still adequate for you. It's still providing you enough oxygen. And we want you to check your saturations also and tell us how they're doing. And, I don't know that I mentioned, but it's important for patients to know from their physician, what should their target saturation be? So it's nice to know for the patient, we want you to keep your saturation between 92 and 94%. And I also would emphasize for patients who need oxygen at rest. So if this patient, when you're sitting in the chair quietly and your saturation is 86%, you fall in a group where we know you need to use that oxygen 24 hours a day, or at least 15, 12, 15, 18, a lot. Because we know for patients that have resting low oxygen, that if you use your oxygen as ordered, it actually improves survival, it increases survival, and it really decreases the load on your heart and prevents pulmonary hypertension. So those patients are a little bit special. They're different in terms of really needing to comply with their oxygen therapy. If you only desaturate with exercise, we don't have as much data on that in terms of long-term effects, but we do know for many patients it enables them to do more and have a higher level of activity. But again, that's an area we don't have as much data in, but important.